Thank you for joining us in the last of this three-part series on stroke education put on by the Allied Health Team at the Pattison Stroke Clinic. My name is Harjinder and I am the pharmacist with the neurology team here. By now, you have heard our first session and have had a better opportunity to understand what stroke is and what common risk factors are. You have also hopefully had a chance to listen to Christine, our dietitian, talk to you about non-drug measures to prevent another stroke. In this final installment of the series, we will be discussing medications and how they are used to prevent subsequent strokes. There are a number of different medications that we might use, but today we will focus primarily on the most commonly used groups: blood thinners, blood pressure medications, and a particular group of medications used to treat cholesterol. Our goals are always to give medications that have the lowest side effects and the most benefit in terms of reducing a stroke. We wish there was a pill that could provide all benefit without any risk, but unfortunately that's not the case. Even if we drink too much water, that too can have side effects. So unfortunately, just because something is natural does not make it void of side effects. The goal today is to empower you to know about some of the common side effects and what to do if these occur. For all patients who have had an ischemic stroke, either due to atherosclerosis, that gunk buildup in the arteries we talked about in part 2, or an actual blood clot that caused the stroke, they will be on some form of a blood thinner. For those who've had those bleeding type strokes or hemorrhagic strokes, we would generally avoid a blood thinner unless you and your doctor have talked about the risks and benefits about restarting one of those medications. The first of this group of medications are the antiplatelets, and these are primarily aspirin or clopidogrel, the other name for which is Plavix. These two medications work primarily by preventing platelets from binding together to form clumps. The other group in this class is the anticoagulants, and they include a very old medication called warfarin and some more modern medications listed here. We'll talk more about that in the coming slides. You may be on one or more of these medications based on your individual stroke risk. For example, you might be on an anticoagulant and clopidogrel, or you may be on two antiplatelets for a short period of time. It is important for patients to know what their specific plan is, how long they're meant to be on combination agents, and it's okay to ask questions to clarify with your doctor, pharmacist, or stroke specialist what your particular plan is. However, we generally don't recommend that you take any extra blood thinning products when you are on one or more of these medications. So for example, any anti-inflammatories like Advil, ibuprofen, or Motrin, or even extra aspirin. If you have a headache, Tylenol is your safest bet, but avoid any additional blood thinners. Warfarin is one of our oldest drugs in stroke therapy, and it is very effective at reducing another stroke. It works by reducing your risk by approximately 2/3. However, it's a really finicky drug. It can interact with a lot of foods, especially those high in vitamin K, like your leafy green vegetables. But this doesn't mean you have an excuse for Christine not to eat these leafy greens, because they're good for your overall health. But you just have to keep a consistent amount in your diet. It can also interact with other medications, and sometimes this means we have to monitor it more frequently, and sometimes we might have to change something. By monitoring, I mean we do a blood test called an INR. It measures how thick or thin your blood is. For most patients, we aim right at 2.5, right between the 2 and 3 listed there. However, in a select few patients, we aim higher. The main thing to remember, if you're on warfarin or any other blood thinner, always check in with your family doctor or pharmacist and say, hey, I'm on this blood thinner. Does this new medication interact? Fortunately, we have some more modern anticoagulants that are just as effective as warfarin and cause less bleeding and don't need all that regular blood work and don't have as many drug or food interactions. They are generally much shorter acting than warfarin, so they have a fast onset, which means they work very quickly in the body, and they have a fast offset, which means the body gets rid of them very quickly. This means to be fully protected from a stroke, you must take each dose every day. Apixaban and dabigatran are twice a day, but rivaroxaban, otherwise known as Xarelto, is only once a day. Another special note about rivaroxaban is you have to be careful with the 20 milligram dose, as if it is not taken with food, you will not get the full effect. So by now you might be wondering, do these blood thinners have any risks? The most common side effect that they cause is bleeding and bruising. For example, a nosebleed that's not stopping, blood in the white of the eyes, coughing up blood. This could be in the sputum, sort of pink tinged color, or vomiting it up. It could be coffee ground colored or bright red. Blood in the urine that could be orange picot colored or bright red, or blood in the stool, and this could be tarry black colored or bright red. If you notice any of these things and you feel absolutely fine, contact your family doctor within 24 to 48 hours. If any of these things happen and you feel dizzy, lightheaded, or more fatigued than normal, you need to come into hospital. We tell you the signs and symptoms not to scare you, but to empower you to know what to do if these occur. There are other things you can do to reduce your bleeding risk. Stopping smoking and limiting alcohol are both keys, especially to protect the lining of your stomach, as both smoking and alcohol can increase the risk of bleeding from your stomach, especially when on other blood thinners. After a stroke, I like to say if you're not going to miss alcohol, don't drink it. But if you enjoy a glass of wine with dinner, and you really want it, I say try to limit it to a glass or a half a glass a few times a week. Your brain needs time to heal after a stroke. So if you can keep other substance use down, this will only help yourself in your recovery. And like we chatted about earlier, don't take other medications that also thin your blood unless you've been specifically told to do so by your doctor. The next group of medications to talk about are those used to treat hypertension. High blood pressure or hypertension is the single most important modifiable risk factor for stroke. There are lots of options when it comes to treating blood pressure. Some of you may recognize some of the names on this page. The ACE inhibitors are the ones that end with pril, like ramipril or perindopril, or the calcium channel blockers, like amlodipine or nifedipine. We generally choose one or more of these based on what other medical conditions you may have and their specific side effects. We'll chat about those in a minute. But it's important to know that there are lots of different options, and sometimes we have to work around, try different ones to find the one that fits the best. How many of you check your blood pressure at home? It's important to know how to do this properly. Measuring blood pressure the right way means being alone in a room where you're feeling comfortable, not too hot, not too cold, putting both feet on the ground and not crossing them at your ankles. Your back is firmly supported. It's important not to be talking and have given yourself at least 5 minutes to sit in this way calmly. Make sure the cuff is not too tight. We generally recommend that you are able to put 2 fingers between the cuff and your arm. You want to make sure the middle of the cuff is at heart level. And sometimes I recommend elevating it, like in this picture, with either a towel or something underneath. It's generally best to do this over a bare arm or a very thin shirt. Avoid taking your blood pressure immediately after a meal, caffeine, cigarettes, or even exercise. All of these things can affect your blood pressure. We'd like you to write down your reading, and if you're still above target, wait 5 minutes and repeat it. You can actually do this for a total of 3 readings, waiting 5 minutes in between each one. Because this takes time, we don't necessarily need you to check every day. It's better to do a really good blood pressure 3 times a week than do a rushed reading every day. So what's a normal blood pressure? Normal blood pressure is between 120 systolic and over 80 diastolic to 129 over 84. The systolic, or the top number, is when your heart is actually contracting. The diastolic, or the bottom number, is when your heart is actually relaxing. In the doctor's office, we want to see you consistently below 140 over 90. And at home, most people are not as stressed as being in the doctor's office, so we actually want to see it lower than that. People with diabetes and certain kinds of stroke, for example, those with a hemorrhage or a bleeding kind of stroke, or those with a stroke caused by small vessel disease, we generally want to be aiming for a tighter target, less than 130 over 80. Like everything else we talked about, blood pressure pills too can have side effects. However, they are generally easy to manage. Sometimes we move the dose to nighttime, especially if you're having daytime dizziness. Or if you develop the classic dry hacking cough seen with ACE inhibitors, we can change to a relative of this class. So talk to your pharmacist or GP about what you're experiencing, because there's often lots of other options. The last group of meds I want to talk about are the statins. These are generally used to lower cholesterol and are the mainstay of therapy to do so. They are an excellent way to prevent another stroke. Even in patients who have an otherwise normal cholesterol, we know that by using this group of drugs, we can lower your risk of stroke by up to 20%. We think they do this not only because they lower cholesterol, but because they have an anti-inflammatory effect. Some patients may not tolerate statins, and they may develop muscle aches and pains. This happens usually in the biggest muscles of the body, in the glutes or the top parts of your legs, or the parts of your arms closest to the trunk. This usually starts early in therapy, so if you tolerate it in hospital, you are unlikely to develop problems when you go home. That being said, if this happens, up to 50% of people can tolerate just switching to another drug in the same class. So don't be afraid to talk to your family doctor about options if this happens. Before we finish, I want to go over some important pearls about your medications. It's really important to keep an up-to-date list of your medications with you, either in your wallet or in your purse. And it's a good idea to write why you're on the medicines you're on, so that other members of your healthcare team can help you if, for chance, you're unable to tell why you're on some medications. For those that are on powerful blood thinners, especially the new ones that we can't do blood tests for, it's nice to have a medical alert bracelet so people know that you're on this blood thinner. Always have enough medications for when you're traveling. If you plan to go away for 2 weeks, take an extra 1 to 2 weeks of supply. Always try to get your refills at least a week before your medication runs out. Don't do what my mom does and call right when she runs out. I usually tell patients to take their medications around a time of day they do something regularly each day, i.e., either dinner every night or breakfast every morning. If you are out for dinner and you forget and you come home and remember, you have time to take it. If, however, you remember the next day, don't double up. Just keep going on as usual. If you are on warfarin and this happens, make sure to let your team know, especially if you have a blood test coming up. If you are having a hard time remembering to take your medications, talk to your pharmacist. There may be many options available to you: dose sets, blister packing, or other techniques that might be helpful. Hopefully, this series has refreshed your knowledge or helped you learn something new about how to prevent another stroke. There are many things in our control after a stroke that we can try to change to help prevent another stroke. Remaining smoke-free, following a healthy diet, optimizing your diabetes, and incorporating a form of regular physical activity. All of these together with your medications as prescribed are used to try to prevent another stroke. We covered a lot today, and hopefully it hasn't been too overwhelming, but I hope that you have a better understanding of the two main kinds of stroke, and that we try to target your treatment based on the cause of your stroke. Coming here today and listening to this series is a big part of trying to prevent another stroke. You are a big part of the healthcare team, and you play a big role in managing your own risk of stroke. One thing we couldn't focus on today because of time was that stroke can really affect our moods. It has been shown that patients can suffer from depression after stroke, and that can affect their recovery. If you or your loved one are having mood changes, talk to your family doctor. Sometimes just going to one of the support groups through the Heart and Stroke Foundation can be enough, and talking to other stroke survivors can often be helpful. But sometimes we need to offer medications. Don't be afraid to receive this offer, and if you are struggling with mood, talk to your doctor. We've listed the Heart and Stroke website there for you, as they have excellent resources. Diabetes Canada is also a very helpful link. And for those that are still thinking about quitting smoking, there are some excellent supports available at the Quit Now BC website listed. Thank you for joining our series, and we wish you well on your journey to stroke prevention.